So can we start? We have told at 11 o'clock, so we'll start. Eh?
Yes, sir, we can start now.
Okay. So thank you, Didaksham Health, for giving me the opportunity to talk regarding the neurofibromatosis, which is one of the common genetic disorders. And I suppose today the audiences were some of the patient caregivers as well as the policymakers or researchers or practitioners who are interested in especially flexiform neurofibroma, where there is a lot of innovative therapies came into the picture. So my first few slides will be a basic introduction of what is neurofibromatosis, what is flexiform neurofibroma, followed by recent innovative therapies and other therapies available in the pipeline for the management of NF1 with flexiform neurofibroma. Greetings from Thiruvananthapuram, Kerala, Government Medical College, as well as Child Development Center, which is my alma mater, where I have done an MBBS, MD, as well as working as a assistant professor and now as a professor and at the Department of Medical Genetics. So, what is the objectives of the sessions? Provide an overview of the current treatment paradigms for patients with manifestations of NF1, explain especially plexiform neurofibromas, explain the complications of NF1-PN that make surgery extremely risky for most patients. Surgery can be done, but you have to select the patients, that is important. Describe the efficacy and safety data of the selmetinib, which is the current considered to be, I cannot say a drug of choice, considered to be one of the drug of choice for inoperable plexiform neurofibroma. So just I will start with the case history. It's December 2023. It's a 3-year-old born of non-consanguineous marriage, delivered by lower segment cesarean section. 3.4 kg term baby, NICU admissions for respiratory distress. Otherwise, child is well, healthy, normal birth weight. Gross motor milestones are normal except unsteady gait noticed by parents. Speech and language and social milestones are normal for each. Parents notice swelling of the right upper limb and hyperpigmented patch from birth. Notice head tilt and unsteady walk and frequent falls at 18 months of age. MRI done and detected a tumor in the neck and resection done in 2022. After resection, there was improvement in hand usage and walking, but the curvature of the spine is increased day by day. Again, admitted in nearby our hospital. That means VS is a exclusive pediatric hospital. Similarly, we are having an exclusive neurosurgery, neurology, a hospital called Sri Tirunal Institute of Medical Sciences, where neurosurgery, cardiac surgery, only 4 specialties are there. So they are referred from outside Kerala and came there for evaluation and operability of this extensive tumor involving the spine. No family history of neurofibromatosis. So by looking at the child itself, the diagnosis come into the mind. By hearing the history itself, you will be able to get as a clinician will get a think of it's maybe probably a neurofibroma involving the spine and extensive plexiform neurofibroma so that it is involved in the limbs and other areas also. So this is the child. You can see an extensive hyperpigmented marks, which is usually seen in the neurofibroma patients. Conscious, playful, and interactive. But that means cognitive function is normal. Earlier also I told that his mental functions are normal. Even now also he is playful, interactive, but only problem is he cannot walk, he cannot stand straight. Thoracic kyphoscoliosis is very severe, multiple cuff folds. Right upper limb is swollen compared to left upper limb, and he is not able to use the right upper limb. Right upper limb usage is very, very minimal. Weakness is there, right upper limb hypotonia and absent reflexes. That means this plexiform neurofibroma is compressing the nerves and there is a nerve damage. Absent reflexes is there. Left upper limb normal tone plus one reflex. Bilateral plantaris extensor and can stand and walk with support only. Can stand but walk with support only. He cannot run. He cannot at the age of 2.5 years. So this is the case which came into my mind to present when there is a plexiform neurofibroma we are dealing with. And MRI spine done in December 2023 showing a large lobulated heterogeneously enhancing lesion in the paraspinal location on the cervicodorsal spine. That you can see that here is an extensive growth. You can see that this is the spine. Spine is totally curvatured and there is an extensive mass. You can see this mass is also extending into the one of the limb. and extending along the paravertebral location as well as into the right brachial plexus to the right upper arm. Also, intraspinal extension at the C5 and C6 level, encasing right-sided subclavian vessels, prominent lymphatic channels in the right upper limb because of compression. So, the diagnosis is plexiform neurofibroma with upper limb lymphedema changes because of obstruction. So, there's a huge plexiform neurofibroma compressing the nerves as well as the lymphatic system. So this is one of the presentation of neurofibromatosis. I think whoever is hearing this, some of the people may have experienced this. So what is actually neurofibromatosis? Plexiform neurofibroma is only one form of neurofibroma. What is neurofibromatosis or NF1? NF1 should be suspected in any individuals who have any one the following clinical features, like six or more café macules. Macule means there is a brownish type of pigmentation, just like coffee on the pot. Coffee on the pot means coffee on the white pot. On the body, you will have a coffee colored pigmentary lesions. Six or more should be there because one or two will be can be present in any individual. It is not an abnormal. Normally, also café macules can be seen. But if it is six or more with the size of more than 5 millimeters in prepubertal and more than 15 millimeters in postpubertal, we consider that is a significant criteria to suspect a neurofibromatosis. But that doesn't mean that all patients with this criteria is having neurofibromatosis because there are so many other genetic conditions where cough can be seen, like spread disease, Noonan syndrome, Turner syndrome. So many other conditions can have cough spot. But when these multiple cough macules are there, you have to suspect it may be a possibility or a pointage to suggest a neurofibromatosis. Then freckling in the axillary and inguinal regions, then two or more neurofibroma or one plexiform neurofibroma. And neurofibroma means it's a small nodular type of lesions which is seen in the along the nerves. It's actually coming from the nerves. It will be small nodular lesion which is measuring from around millimeters to centimeters. It may not be very huge. Whereas plexiform neurofibroma is involved in one part of the body with extensive enlarged plexiform neurofibroma, just like I have shown. Again, we will see the photograph of some of the things. Optic pathway gliomas, that means optic pathway. Optic pathway means the vision. Vision, there is optic nerve is there, optic chiasma is there, optic tract is there. In any of these areas, there can be optic gliomas. That's actually a glioma means it's a tumor. That glioma, which is very, very common, it is seen in around 6 to 8 or up to 10 percentage of pediatric patients with the neurofibromatosis presenting. Two or more Lish nodules. Lish nodules are eye abnormalities which can be identified by slit lamp examination. So they may not give any symptoms, but when we will see other symptoms, we will ask them to examine ophthalmologically to look for Lish nodules. And distinctive osseous lesions like sphenodysplasia or pseudoarthrosis of long bones. That is very important, like tibia or a humor or femoris, where there is a long bones will have a automatically there's a break and there's a joining in that. This is called a pseudoarthrosis tibia, which is can also be a presenting symptom in neurofibromatosis, which most of the clinicians may miss. I have seen pseudoarthrosis diagnosed in the newborn period and finally diagnosis of NF1 has done at the age of 4 or 5 years only because they have done just a plastering and some treatment there. Nobody has thought of NF1. But finally, when it comes to a tertiary care hospital, they have suspected NF1 and diagnosed the disease. So pseudoarthrosis may be a presentation even in the newborn period, just to newborn baby. A parent who meets diagnostic criteria for NF1 because it is a genetic disease, it is an autosomal dominant disease. That means one of the parent may be affected, but that is not mandatory because it can occur by a sporadic also. Sporadic means a new mutation can occur in a baby when the child is developing in the womb with one sperm and one ovum will join and embryo will develop. At that time also a mutation can occur causing the disease or there may be one of the parent will be affected. So one of the parent is affected, there is 50% chance of transmission of the disease to the offspring. And we have to identify a germline pathogenic NF1 variant by genetic testing. So this is the, in nutshell, in a brief, as an introduction to neurofibromatosis. So this neurofibromatosis can produce so much abnormalities. That is why we are very much bothered about it. Like you can see that, 1 minute. You can see that there can be disfigurement There can be, already I told you, because it's a plexiform neurofibroma will produce a disfigurement. There can be skeletal abnormalities, like it can be a scoliosis or kyphosis, or it can be a pseudoarthrosis tibia, where it can be a bowing of the long bones, or it can be a motor dysfunction because of the plexiform neurofibroma involving one of the lung. There can be headache, macrocephaly, large head may be there, pain due to multiple neurofibromas, it may be a tingling sensation, reduced life expectancy because of it. It's a cancer-prone disease, and cognitive and behavioral deficits, they may develop like seizures and the thing. Visual impairment because of optic glioma, airway obstruction because of plexiform neurofibroma obstructing the upper airway, bowel and bladder dysfunction because of plexiform neurofibroma involving the pelvis. So it is a multisystemic involvement. Just to show you, multisystemic involvement, any type of symptoms can be occur due to neurofibromatosis. And another major problem is neurofibromatosis. One is a tumor predisposing condition. It can be a low-grade tumors like glioma or neurofibroma, cutaneous or plexus. These are all actually tumors only, small, but they are all very, very mild and not like a malignancy where it will spread or something like that. But sometimes these gliomas or neurofibromas can turn to malignancies. Commonest is malignant peripheral nerve sheath tumor. There is a malignant transformation of a plexiform neurofibroma can occur. And there are also more found gastrointestinal stromal tumor, pheochromocytoma, breast cancer, duodenal carcinoid, rhabdomyosarcoma, and JML, juvenile myelomonocytic leukemia. All these patients should be followed up or deeply look into this for these type of complications because NF1 can produce all these type of tumors. But that means everyone will not get because it's a very comparatively common genetic disorder. I have seen hundreds of cases. Very few cases are developing this 2%, 3%, or 4%. But compared to a normal population, NF1 patient have more chance to develop these type of tumors and malignancies. In our genetic clinic, it is a genetic testing. This is a last year data. I have not updated the data. It's a total number of patients confirmed is genetic 25. Now it will be around 35, 40. But I have taken only genetically confirmed cases. That's why I told I have seen more than 100 cases. Every cases we will not do genetic testing because genetic testing will help you to confirm the disease and do genetic counseling. Since it's a little bit expensive, everybody will not will not accept it. We will counsel them, but sometimes they would have been completed the family, sometimes they are not married, they are not going for offsprings. So they will tell why should we do sir? Just I came because it's I know that genetic department is there or genetic clinic is there. Like, so many cases will not be done, especially adult patients. Whereas cases like optic glioma, because their diagnosis is required. Neurosurgeon will ask optic glioma because of neurofibromatosis or optic glioma without neurofibromatosis. Little bit options and treatment is a little bit different. So in this all optic gliomas, we used to do genetic testing. Other tumors like angiomyolipoma, CNS manifestations, MRI suggestive, pseudoarthrosis tibia, 3 cases, plexiform neurofibroma, 5 cases, skin lesions for genetic counseling, 5 cases. So you see, it is not a classical neurofibroma we have not done because people will not come because already in family multiple members, right? His grandfather is there, father is having. So they will feel that okay, this disease which is friend in families, why should we go? So they will not come for genetic testing or genetic counseling. So these type of complicated cases only come for that is why that doesn't mean that that case number is very low. It is only a tip of the iceberg where patient have significant symptoms and complications. They come. I have just shown you to show that what type of test you have to do. You can approach a geneticist to look for a exome sequencing where around 95% cases can be identified, but some of the cases may be missed even in exome because of some specific micro deletions or things where you have to do MLPS. So genetic testing is also not that much easy because it's a very large gene. Multiple exons are there, so simple sequencing cannot be done. We have to do next generation sequencing high-end platform. Exome is the first test you have to do, where 90 to 95% cases will be picked up. But sometimes you may not you missed it. So if it is a missed in a case and if you are strongly suspecting NF1, you have to opt for gene targeted deletion duplication analysis by MLPA or a chromosomal microarray or a those type of deletion duplication specific tests. Just to know that testing is also not very simple. Otherwise, I don't want to tell you the details about the testing. You can approach to a genetic department or a geneticist for testing of the genetic testing. So in this patient, we have done the genetic testing where there is a and exon 17. So you see dot 1982, the same patient, because only one patient I'm showing in my name. So how that came, I have told. Second thing is they have done a genetic testing. Genetic testing shown that it's a termination mutation, heterozygous NF1 autosomal dominant, and it's a de novo. Parents are absolutely, both of the parents are not having any symptoms. Their genetics is not showing this mutation. So it's a de novo autosomal dominant mutation in the NF1 heterozygous causing the disease. So this is other some of the mutations which we have seen around 25 to 30 cases. I have just taken just to show you that every mutation is individualized. No repeat mutation. That means in other genetic conditions like achondroplasia, thalassemia, or SMA, or DMD, same type of mutation we'll see in multiple patients. Here it is not like that. Every patient will have, or every family will have a specific mutation, which can be a missense mutation, which can be a nonsense mutation, or a frame shift mutation, or a stop gain, or base pair deletion. Different types of mutations are described in neurofibromatosis. Our data is also showing that mutations are individualized, patient specific, and very common area or common mutations we may not be able to identify. Okay, it is not moving. Okay. So while coming to plexiform neurofibromatosis, plexiform neurofibroma, already I have shown that the patient, irregular, thick, and non-circumscribed tumor of peripheral nerve sheath, which can multiple nerve facilities, not like others. Others tumor, most of the time you will say that small millimeters to centimeters, nodular swelling will be there. Some are seen in the periphery, some are inside only, but it may not be a very big. Whereas in the plexiform neurofibroma, these are large, irregular, thick, and non-circumscribed tumor. Peripheral nerve sheath will be affected. Multiple nerve vesicles will be affected, so that it will be a huge, large, it can produce a pain, it can produce a discomfort, it can produce nerve compression, it can produce lymphatic compression, it can produce other areas compression, etc. And the only thing is, I have shown you one case, and I have shown you we had already 5 or 6 cases came to the OPD saying that we are having plexiform neurofibroma, but 15 to 30% clinically identifiable. But if you do the whole body MRI, it may detect 50%. That means some of the intra-abdominal or intrathoracic or a inside bulk for neurofibroma may not be identified or may not be symptomatic. They can present with any type of symptoms and a slow growing and locally infiltrating and minor discomfort to extreme pain depending upon the site, depending upon the size, etc., which we will come next slide. So, plexiform neurofibroma is a common and often debilitating manifestation of the NF1. So, debilitating tumors in 50% of the patient in NF1, already I showed you, MRI will show a more thing, arises from one or multiple nerve bundles and can be congenital or appears as early as birth and develops rapidly in childhood. You can see that it's a thigh of the patient. Child cannot sit, child cannot walk like other patients. Child cannot put dresses like other patients because it's a huge plexiform neurofibroma involving the thigh. So this is the problem of the plexiform neurofibroma, which can be disfigurement, which can be pain, which can be a obstructive symptoms, etc. And it can occur any site. For example, you see the face. I have seen so many patients with the extensive plexiform neurofibroma and the orbital area. You can see the first patient disfigurement and functional impairment is there. Sometimes it may be a surgery possibility, may not be there. For example, in head and neck, surgical things are very difficult because of complex tissue involvement. Can be extremities like this, or it can be thigh, like previous patient also we have shown. And always there is a 10% risk of MPNST. I told you the risk transformation to malignancy for other thing. For example, a general risk of a neurofibroma, simple neurofibroma is very low. That's why we are not removing it. It is extremely low, but it is there compared to a normal individual, but it is not very high. Whereas plexiform neurofibroma is having a 10% risk of transmission into no, malignant transformation of nerve sheath tumor with severe pain, and we have to do the extensive surgery, and it is having a poor prognosis. So, plexiform neurofibroma is the situation where we require some treatment modalities required. This can be classified based on the morphology, like diffuse, or it may be fascicular or multinodular. For depth, it can be a tumor arising from deep to the muscle fascia, or tumor superficial or the muscle fascia, or it may be interdigitating or circumscribed, and special type like spinal neurofibroma, distinct nodular lesions, or streaky appearance. So, this the for the clinician's point of view, surgical point of view, to analyze the complications, we will divide this plexiform neurofibroma into diffuse neurofibroma, or a localized neurofibroma, or a vesicular multinodular. Depth also it's a superficial or a deep. Because some of the, that's why we told the whole body MRI, because some of the plexiform neurofibroma will be extensively seen in the intraperitoneal and thoracic, but we will not see anything outside. So the patients will be totally, symptoms will be related to intestine or related to chest or a stridor or a respiratory difficulty, etc. Only by doing the MRI, you know that a huge plexiform neurofibroma is present inside the thorax. And always the diagnosis of choice is MRI. You can do regional MRI or a whole body MRI. For the diagnosis, always whole body MRI is preferred, and screening tool, whole body MRI. But for surveillance means for the evaluate treatment purposes, regional MRI is enough, because as you know, whole body MRI is very expensive. So somebody will ask, the whole body MRI has to be done for every patient. That's a very difficult or tricky question. Some of the experts in the Western countries, or who are dealing with only plexiform neurofibroma and doing research in plexiform neurofibroma, they felt that you have to do the whole body MRI for every patient, then only you will identify. But I think a country like India, where constraints are there, developing country, lot of constraints for MRI and financial constraints are there. I think it is not required. And it's my opinion, it's not required for every patient, but a physician or a clinician who is an expert in neurofibromatosis feels that there is something inside, we have to do whole body MRI, better to do whole body MRI. But it is not required for every patient, where 5 or 6 neurofibromas are there. We don't have any other symptoms. We don't have any symptoms suggestive of plexiform neurofibroma. There is no meaning in doing unnecessarily whole body MRI. But if there is any early symptoms or suspicion there for a clinician, then whole body MRI has to be done to assess what is the extent of involvement of plexiform neurofibroma, which is important to decide on the management like surgery, targeted therapy, follow-up, etc. So, what are the treatment of NF1? There is no single cure for NF1, but lot of treatment options can help to manage signs and symptoms. You don't bother about why I have told no cure. That is very important, because everybody should understand most of the diseases cannot be cured. Most of the diseases in the world, not genetic disease, cannot be cured. All diseases we are controlling only or caring only. So here also you can control a lot. A proper diagnosis, follow-up, surveillance, and treatment will have a good prognostic factor in patients with neurofibromatosis. Neurofibroma, you can do surgical resection, should be considered when neurofibroma causing cosmetic disfigurement, pain, or compromised function, especially in the face or somewhere. Early itself, if possible, you can do the neurofibroma surgery. Bone problem includes demineralization of bones and non-ossifying fibromas affecting femur, tibia, humerus. Interventions include supportive measures and treatment of fractures. Scoliosis, multiple forms of scoliosis. Some forms may require surgery, while others can treat. Because, for example, I told you, our case, first child, they have done the surgery for correcting the scoliosis, but it will not be corrected, because again, the plexiform neurofibroma is growing in the pediatric age group. Again, it grows, again, it produces scoliosis. Optic glioma, usually grade 3, grade 4 astrocytoma require aggressive treatment. Best outcome is with complete surgical removal coupled with the chemotherapy. But most of the time, surgical removal will be difficult because the vision loss will be there. So probably we will treat with chemotherapy, look for vision loss. If vision loss is not there, follow-up, close follow-up is required. Any spread of the disease or any enlargement of the disease causing vision loss, there is no meaning in waiting till it produces a lot of complications. You have to do the surgery, which will definitely cause the blindness to that eye. MPNST, that is a malignant transformation. Treatment involves complete surgical excision with chemotherapy. Learning disability in case of academic difficulties, a complete neuropsychological evaluation, intellectual testing, and supportive therapy. Speech problems also aggressively addressed, individualized speech therapy. So there are multiple symptoms are there, multiple treatment is there. So you have to identify the symptom, identify the problem, and treatment has to be conducted. So that is the importance of enough clinics, multidisciplinary care. So a single patient, single doctor cannot be expert in all those things. So there should be an NF expert. This expert can be a physician, this can be a pediatrician, a neurologist, or a geneticist. These are the four groups of patients maximally seen the NF1. So these patients can be one of the expert. That doesn't mean that always geneticist is required. One of the person who deals with the NF1 regularly, and these patients can have a diagnostic radiology, genetics, ultrasound, etc., medical and surgical, primary care, neurology, cardiology, plastic surgery for extensive neurofibromas, oncology, ophthalmology, neurosurgery, orthopedic, surgical oncology, supportive oncology, then psychological support as well as nutrition, neuropsychology, etc. So it is a multidisciplinary care clinic coordination is required. So enough expert will be in the center. He will decide on what is the treatment required at present, and he will refer to the concerned specialist. Coming to the plexiform neurofibroma, which is our um, part of the important talk because where more number of treatment options are coming. Surgery is one of the few treatment modalities for cutaneous or subcutaneous NF1 tumors. Surgeon should be part of the multidisciplinary team, and surgery might be considered in some cases to remove small manifestations in the young age, that means in the site. But surgery can improve quality of life, pain, functional deficits, disfigurement, spinal cord compression, or air obstruction. There is no doubt it. But surgery depends upon various other things like size. Tumor size is associated with the risk. Small and or isolated complete resection possible in small things, whereas large, interdigitated, rapidly expanding lesion. Actually, I have shown my patient where it is a very extensive spinal neurofibroma where surgical excision is not possible. Similarly, patient age, younger age group always has a chance of recurrence because this flexible neurofibroma will grow rapidly in the younger age up to 15 to 20 years. So if you do surgery in 2 years, 3 years, again it will be rapidly growing. Within again 3 years, you have to do the surgery. I am having a patient with the flexible neurofibroma at the age of 15 years. She's having extensive flexible neurofibroma of the one limb. Already she had undergone four surgeries. So surgeries in younger age group, you require repeated surgeries. Symptoms and morbidity, disfigurement and pain, life-threatening symptoms like airway obstruction, which may not be handled surgery may not be possible. I will one of our case where the patient comes with extensive thoracic flexible neurofibroma with stride respiratory obstruction. Where surgeon told we cannot do anything. Where we have started the treatment of selvitinib, where the size has been reduced dramatically and symptoms has been gone. That doesn't mean that it is totally flexible neurofibroma has gone, but size has been reduced, pressure has been reduced, compression has been reduced, life has been saved. Tumor location can hidden complete resection. Superficial PNs are easy to remove, whereas PNs near head and neck or paraspinal hinder complete resection. Same like these two patients. Growth rate is often unpredictable with periods of rapid growth is very and patient or caregiver preference is very, very important. So necessity of an expert plastic surgeon is very important. Difficult a plastic surgeon with ample experience is important to manage potential complication and challenges associated with enough fund. Depth of neurofibroma, increased bleeding, scarring, nerve damage, everything should be managed because it is not a very easy surgery. So that is why I told in our hospital also most of the neurofibromas are managed with the peripheral neurofibromas are managed with the plastic surgeon. And neurofibroma can be excision or destruction, two types of surgery. But most of the people are, as far as my knowledge, my understanding, doing excision only. Destruction may be a newer technique where our hospitals or our Sundays, non-Sundays are not doing. Like, but electrosurgery can also be tried. In younger patients, you can see that the growth of the neurofibroma, you can see that the younger age group, the growth will be very, very high. Okay, person turnover changes per year, whereas when it is gone beyond 20 years, 30 years, there is not much growth. So children are at high risk of associated with poor prognosis because high risk of poor surgical outcome. English tumor growth is left untreated and higher rate of progression in patients less than 21 years. So younger age group, rapid progression, rapid growth of the tumor. So and tumor response, treatment response may not be that much high. So shorter time to post-surgical relapse, already told you, less than 15-year-old child with a forced surgery. That is a thing which you should remember. And challenges in surgical treatment is nerve damage, blood loss, functional impairment, and wound healing abnormalities. All this will have a problem. And risk of developing complication generally increases with size. And a smaller neurofibroma, even if it is small, high risk is located in sensitive body regions like near eye or near the other vascular structures, etc. So post-operative recurrence are based on the age, location, tumor volume, growth type, and incomplete resection. So risk of progression after surgery is increased in children less than 10 years. Tumors on the face, neck, trunk, and residual with increased post-operative progression. High residual tumor will have a relapse. Deep and diffuse PNs residual with increased post-operative progression. Patients with incomplete resection have a shorter time to relapse. So important thing is all these factors will. So two problems. One is surgery is the treatment of choice. There is no doubt even now if it is possible. But surgery is having a lot of complications, morbidity and difficulty. Similarly, surgery is having a possibility of recurrence also is there. It is the same case which I told. Where it's a targeted therapy case. So what is targeted therapy? It's a pathogenic variant of NF1 gene. Already I told it's a neurofibrate. What is its function? Function of this NF1 gene in the body is to control the growth pathways, whereas this gene is defective or not functioning because of mutation. Mutated NF1 gene encodes defective neurofibromin production. Growth pathways are unregulated and excessively stimulated, causing tumor formation. Large NF1 gene can be susceptible to mutations. So this is the NF1. You can see that it's a wild type NF1 which will inhibit the RAS pathway. It will inhibit the RAS pathway. When RAS pathway is inhibited, these all pathway will be inhibited. So cell growth will be controlled. You can see here inhibition. Normal NF1 will inhibit RAS. If RAS is inhibited, all the successive molecules will be inhibited so that it's a controlled cell growth in a normal cell. Whereas when there is NF1 is mutated, this RAS inhibition will not be there. It will activate the RAS. When there is activation of the RAS pathway, all these subsequent molecules will be activated. There is uncontrolled proliferation of these cells, which causes the tumor formation, like glioma or neurofibroma or other type of malignancies, etc. So this is the importance of NF1. A mutation in the NF1 will prevent the normal control of the cell proliferation, which causes uncontrolled cell proliferation and tumor formation. So this RAS, this pathway this can be a RAS, it can be MEK, it can be RAF. So one is RAS signaling inhibition like tipifarnib has been tried first. Sirolimus and everolimus is the mTOR pathway inhibition. But more recently, I'm not going to the details of these molecules. More recently, MEK inhibitors like selvitinib, promatinib, binimetinib, and mirdimetinib. MEK inhibitors means these are the MEK inhibitors. Even though mutated NF1 which stimulate the RAS, after this RAF, this MEK also has to be activated for control proliferation. So these drugs will come in this position and block this MEK. That MEK inhibitors can be four types: selvitinib, prometinib, binimetinib, and mirdimetinib. And most of this prometinib is also tried in the NF1, but maximum study and came with the selumetinib. So this is the same thing. Selumetinib is an oral second generation MEK inhibitor developed for the treatment of NF1 plexiform neurofibroma, which will prevent this MEK so that cell proliferation will be prevented. It is the treatment of pediatric patients with NF1 and symptomatic inoperable plexiform neurofibroma. So evaluated salmeterol for the treatment of inoperable NF1-PN aged 2 to 18 years, less than 2 years it has not been studied, and studied in NF1, especially inoperable plexiform neurofibroma causing morbidity. Phase 2 study, statin 50 patients. Salmeterol was given in 25 milligram per meter squared per dose and continuous dosing of 28 cycles, open label single arm, and primary endpoint was complete and partial response measured by volumetric MRI. Confirmed partial and complete response at each response, duration of response, effect of quality of life, disfigurement, physical long-term safety and tolerability, pharmacodynamics. These are the secondary endpoints they have studied. So what are the patient group? 50 patients were there. Median age was 10.2. Sex 30, 20, 30 male and 20 females. Progression status for is 21, 15, 14. And it's progressive in 21, non-progressive in 15, and insufficient data in 14. Target PN classification is typical nodular solitary in 45, 4 and 1. Median target PDA flexible neurofibroma volume was 487 ml. So this is the basic characteristics of the size. And what is the response rate? This is very important. Complete response is zero. That's I told. No drug has been identified so far for NF1. which you start even in early, it will completely prevent the development of neurofibroma, because categorically you have to tell to the patient that that is not possible. That is not the indication what we are facing, which is not possible also. But partial response, which is seen in 37 cases, confirmed partial response in 34 cases, durable response in 28 cases. What is this partial response? Partial response is more than 20% reduction in the tumor size by the treatment with 1 year, 6 months. Periodically, they have tried. So, more than 20% reduction in the tumor size should be there. That is the partial response, which is confirmed by the MRI, all body MRI, volumetric MRI is 34 patients. That is this 34 number. The durable response, which is continued beyond 18 months or 2 years, is the durable response. So generally, we can say that definitely size of the tumor mass will come down to 20 to 30% reduction. Definitely, you will get median time to initial response is 8 cycles. That's around 8 months. 28 days, one cycle. 8 cycles. Median time to best response is 16 cycles. This is the first important major study of sprint phase 2 trial. This is the same with figure. You can see that except 1 or 2 patients, most of the patient tumor volume has been drastically reduced. These are the different patients and where it is how much reduction was there and significant reduction in most of the patient tumor volume. So this is the MRI figure. You can see the baseline figure. You can see how it is compressed. This is the baseline figure. This is it. I will show my patients also later how they responded, not by MRI, clinically also. So, what are the clinical outcome measures? This is their symptoms, how this pain interference, how this other thing, apnea, all symptoms, wherever symptoms, because they have taken 50 patients. I told you, 50 patients will have different symptoms. How the symptom improvement was there in most of the patients, you can see. So, generally, we can say that symptomatic improvement is there, tumor reduction is there, compression will come down, but it will not go to 0% cure rate. So, we cannot say as a cure. This is the same change in related complications, minimally improved, much improved. Another pattern of showing the improvement is not total, but there is at least minimal improvement is definitely there, most of the patient. And strength and range of motion, 33 subjects with a deficit in strength. Only those patients has been they have selected. Deficit in strength and range of motion at baseline. Abnormal muscle strength in baseline was 21, and increased average strength of muscles in pre-cycle 13. That is a significant, is p-value less than 0.001. That means significant improvement in muscle strength, significant improvement range of motion. Both has been noticed in around 50% of the patient. I told you, because it's a heterogeneous population, so symptoms will be different. Every patient may not have same symptoms. So wherever there is a weakness was there, weakness has been improved. So naturally, every drugs we have to look for side effects also. These are the side effects profile: vomiting, abdominal pain, diarrhea, nausea, oral mucositis, etc. You can see that 50 patients, site is around 2, 3. That's all. Only rash is the significant symptoms in most of the things. We have also seen rash seen in some of the patients. This is the treatment cycles: first cycle, second cycle, third cycle. So, first cycles, every patient will have nausea. So, my patient is also first few months intolerability. Nausea was there, some not a complaint, we can say, because it's a young child, 2.5 to 3 years. But he's having a rash in between, it will come, but automatically it will go down without any treatment. So, some of these milder symptoms has been described in our patients also. Lab values, major or one of the major thing what we have seen in increased CPK, which is also seen in our patients, but with the continuation of therapy, it has come down. You can see that all where CPK is mild elevated, rest of the symptoms are not very many. Fatigue was there, anemia was there, but everything has been subsided with the continuation of therapy in second or third cycles. So definitely we can know that in the early part, first month, there are some mild symptoms. These mild symptoms can be corrected by continuation of therapy with the proper measures. But there is no serious side effects which causes even a single patient to stop the drug, or no death or any other complications has been. Asymptomatic CPK increase, GI toxicity, mucositis, and fatigue are the common symptoms. And 99% are grade 2 only, less than grade 2 only. There is no significant symptoms which causes a stoppage of the treatment was required. So long-term safety and efficacy of selmetinib has been published, which shows that significant improvement was there, significant safety is there. So with this much about the targeted therapy, this is our patient, which already I have shown you. You can see that he cannot stand. He can stand with support only, walk with support only, with extensive plexiform neurofibroma involved in the spine and upper limbs. We have started salmeterol 10 milligram 3 times daily, 2 in the morning and 1 in the evening. Considering his dose, 60 tablets per bottle, significant motor skills improvement, no adverse effects, completed 11 cycles so far. It is in the 3 months, 4 months back. Started in January 2024. So almost 2 years is over. And after treatment with salmeterol, still scoliosis is there, but he can stand independently. He can take some things from the floor independently. He can walk independently without anybody's support. He can play with the and some recent figures. You can see still here the right upper limb movement is limited, but he is using. But some recent photographs also show the right upper limb is also more better. So definitely his motor strength has been improved. Symptoms has been decreased because of the decrease in the size. And recently, that I have not included here. Recently, we have done the MRI after 1.5 years, 18 months, and his we are not able to do the volumetric MRI. That is a specialized type of MRI. Only the research people who are doing this can be done. In our setup, our radiologist told it is a little bit cumbersome and it is very extensive, infiltrating. So volumetric MRI cannot be done. But by taking the different measurements and by seeing the compression pattern, he has given a report that around 20 to 23% or 25% of reduction in the tumor size, which we can see by comparing the MRI itself. More than that, as a clinician, as a parent, they are also feeling patient is definitely improving. Symptoms are decreasing. But I'm sure that it will not go zero. Definitely, we have to give the drug for a long time for continuation of the improvement. So, along with salmeterol, other drugs are also tried, like trametinib, binimetinib, etc. Also has been tried. Everything is in the phase 3 trial and phase 4 trial. Some data is not available. These drugs also make inhibitors may come as a competitor to salmeterol in the recent future. Other drugs like erythropoietin, that is a EGFR inhibitor, PDGFR inhibitor, VEGFR inhibitor, mTOR inhibitor, etc. been studied. Some are not effective, some are positive response. So response is depending upon the condition, different things will vary. So this is also some of the things which is in the pipeline. Newer drugs are also coming for the treatment of NF1. This is about the NF1 current overview of the what is NF1, what is plexiform neurofibroma, different types of presentation, complications, different forms of therapy, including some of the newer molecules. I'm stopping my presentation here.